So good morning, ladies and gentlemen. My name is Jens Chapman. It's my distinct privilege to welcome you here to the Orthopedic Grand Rounds. Today's topic pertains to one that really affects all of us in our families and in our daily work. As all of us know, our demographics in our country are shifting dramatically towards an aging population. In a way, this is a success of modern medicine, but it's definitely something that really has hit home hard in terms of an ever-aging and more vulnerable population presenting to our emergency rooms. Today, our fourth-year resident, Grant Lohse, back here, has done a wonderful job putting together a mini panel for this symposium in which we will discuss these problems that we're all facing. First off, we have Dr. Itamar Abrass here. He's a professor and division head for the Division of Gerontology and Geriatric Medicine at Harborview. And next to him is Dr. Wayne McCormick, professor and section chief for the long-term care division in internal medicine. Finally, from the Department of Orthopedic Surgery, we're proud to present Dr. Lohse Tatesman, associate professor and the head of our Geriatric Fracture program. These four physicians will talk to us about how we are facing this crisis right now and what paths we can do or embark on to try to improve outcomes. I'll ask Grant to take the lead here. And again, we'll have a chance to discuss some cases later on. So Grant, lead us to the program.
Thank you, Dr. Chapman. So today we're going to be discussing fragility hip fractures, and we'll have some multidisciplinary considerations. As Dr. Chapman mentioned, we are fortunate to have with us representatives from both the Department of Gerontology as well as the Department of Orthopedics. We're going to start with two cases for your consideration. We're just going to present them now. We'll discuss them again at the end of the talk in more detail. The first case is a woman in her mid-70s who falls while playing tennis. She's generally healthy and quite active both mentally and physically. This is her x-ray demonstrating an intertrochanteric hip fracture. The second case is an older individual whose health and functional status have been declining as of late, requiring him to move in with his son a few years back. He does not recall the circumstances surrounding his fall. This is his x-ray demonstrating a femoral neck fracture. So let's start with a few definitions just to ensure we're all on the same page. For the purpose of this talk, we'll be using the definition of a fragility fracture that is an osteoporosis-related fracture that results from a low-energy mechanism, such as a fall from standing. The disease burden that we face from these fragility fractures is significant. The number of fractures is measured in millions, and the cost in billions. About half of women and a quarter of men will sustain one of these fractures in their lifetime. The most common of these fractures is a vertebral fracture. The other category representing proximal humerus fractures, ankle fractures, forearm fractures, etc., also represents a large number. However, it is really the hip fractures that are have the most impact in regards to both their human and financial cost. You can see that while hip fractures only represent about 15% of the volume of fragility fractures, they account for over 70% of the total cost. Looking at this another way, the cost per fracture for a hip fracture far outshadows all others. And this is really due to the use of operative intervention that these often require, long hospital stays, and long periods of rehabilitation. Hip fractures, of course, we all know have significant morbidity and mortality associated with them. A person sustaining such fracture only has about a 50% chance of returning to their pre-morbid level of walking independence. So that means if they did not require an assistive device prior to their fracture, about half of them will require a cane or a walker after their fracture. And if they did use an assistive device previously, they may require additional assistance and even lose their functional independence. This is some of the most recent mortality data I could find in a literature review. This is out of a study published just about 10 months back. It looked at about 750,000 Medicare patients. And as you can see, mortality, even in recent times, remains very high, and the mortality rates for men are about double that for women. So who sustains a hip fracture? Well, most commonly it's a woman in her mid-70s who has a typically ground level fall. The risk factors for these type of fractures are fairly well known and well studied. A few of them are listed here. It's worth presenting or pointing out that advanced age actually has an exponential relationship with risk. Individuals 85 and older are about at a 10-time greater risk than their 65-year-old cohorts of sustaining a hip fracture. The increase in number of fractures is fairly common knowledge. However, the basis for this estimate is interesting and deserves some attention. The incident rate, which is the number of fractures per 100,000 population, actually peaked in 1995 and then started to decline. Now, temporally, this roughly corresponded with the introduction and widespread use of bisphosphonate therapy. But best estimates would say that bisphosphonate therapy could only account for perhaps 40% of this reduction. So other theories have been the use of vitamin D, calcium supplementation, increased awareness, and other such factors that have contributed to the decline. As Dr. Chapman mentioned, we are facing an aging population. Over the next 20 years, the number of Americans 65 or older is expected to double. So thus, even in the setting of a lower incident rate, the absolute number of fractures is expected to increase as the denominator grows. One other trend worth analyzing is mortality data. We've already pointed out that mortality remains a significant problem. And what's interesting is up until about 1998, we saw a steady decrease in mortality. However, across age groups and gender, the mortality rate has really plateaued since that time. Some of the early reduction was felt to be due to better use of perioperative antibiotics, recognition of the importance of early mobilization and other such measures, but we really have not made too much progress in recent time. So this is a challenging patient population. They have a significant number of comorbidities associated, and these are well beyond the expertise of most orthopedic surgeons. It really highlights the need to involve a geriatrician or an internist in the care of these patients both early and often. So with that as background, I'm going to reintroduce Dr. Abrass to discuss with us some of the preoperative medical considerations in caring for this patient population.
So what I'd like to do is review with you some of the aspects of the impact the geriatrician would have in the initial care of a patient with a hip fracture, and then we'll talk some more at the end during our question and answer period about the cases that we presented to you specifically. So our role in managing these patients includes several things. Particularly, we want to assess the cause of the fracture, and you saw the data that 90% of these individuals fall. So the question really is, why did they fall? And that's important both in our preoperative assessment, but also in our management of the patients after they've been treated. And we'll talk some more about that as well. We want to assess the operative risk of the individual. We want to maximize that patient's opportunity to go to surgery and have the fracture repaired. And we want to provide longitudinal care for the patient, and we want to manage any medical complications that the patients may have. And you already saw the comorbidities are very common amongst these patients. So when we assess the patient for their cause of their fall and their fracture, I think the most important thing is that we do want to assess why they fell. Cardiac symptoms for us are very important, so we assess the patients as best we can for any cardiac symptoms that led to their fall. We also want to know about neurological symptoms before the fall. And certainly the question of loss of consciousness and whether that occurred prior to the fall or after the fall. So part of what we want to do is to assess the patient's operative risk. And what we look at are issues related to patient-specific risks and then also the surgery-specific risks as we evaluate the patient. So I think from a surgical procedure perspective, most orthopedic procedures have been determined to be of intermediate procedure risk. So that's the general concept of the operative risk. What we see in most of these patients is that this is really what we would consider an urgent procedure, in the sense that we want to take the patient to the operating room as soon as we can. And there's really pretty good evidence that surgical delay is associated with a whole host of both decrements and are a problem, and early surgery has benefits. So the data certainly suggests that delay of repair of the fracture is associated with increased mortality. There are increased major complications. The risk for development of a decubitus ulcers goes up, and obviously if the patient's not going to the OR, they're going to have preoperative pain that needs to be managed. The benefits, though, of early surgery is that the patients generally have earlier ambulation, and they have a shorter length of stay in the hospital. So the present general recommendation is that surgery should be performed once the patient is medically stable, and that's part of why we're involved in the patient care. And this should be within 24 hours if possible. So our goal has been, in managing these patients with our orthopedic colleagues, is that the ED evaluation, including orthopedics and geriatrics, be completed in 2 hours. In other words, getting the patient out of the emergency department within 2 hours. If we can, we take the patient directly to the OR. If they're admitted, the operation would be scheduled within 24 hours, and those are our basic goals for these patients. What are we looking at? So the cardiac risk assessment and reduction is what we're looking at most of the time in assessing the patient for surgery. You've seen all kinds of guidelines and algorithms for outpatient assessment, and those complex algorithms, I think, don't really fit this patient population because we're really talking about an urgent procedure. And so what we've learned is that when severe coronary artery disease, heart failure, or severe aortic stenosis are excluded, pre-op cardiac catheterization does not improve mortality or post-op myocardial infarction incidence. So there's really no good evidence that delaying the surgery, unless these individuals have these very significant cardiac complications, that they should be delayed as far as surgery is concerned. So really for us, when we see these patients, we really ask the following questions. Is there unstable coronary syndrome? What we're talking about are people who actually have symptomatic angina or have had a myocardial infarction within the last 30 days. Do they have decompensated heart failure? Do they have a significant arrhythmia? In our patient population, that often means atrial fibrillation with a rapid ventricular response. Certainly symptomatic ventricular arrhythmias would be something we would want to manage before surgery. And then the whole issue of severe valvular disease, and again, in our patient population, that usually means symptomatic aortic stenosis, and those patients may be delayed. If none of these are really present, we generally direct the patient to the operating room. So the other issue, of course, in our patient population is because they're often on many medications, is we always consider the risk versus the benefit of medications. I think most of the time we continue the medications the patients are on. There are really very few that really need to be stopped. We typically would stop loop diuretics, but not hydrochlorothiazide, probably. And we would stop metformin if the patient is a diabetic on that drug. And then most of the other drugs, we would keep the patient on those as they go to the operating room. We have special considerations for beta blockers. This has been something that's waxed and waned over time. The present recommendation is that it be continued if the patient is on it. We would consider initiating it preoperatively, if the patient's going to go to the OR within 24 to 48 hours, only if they have significant symptomatic coronary artery disease. Otherwise, even if they have other cardiovascular risk factors, we would not start it. If we do start it, the goal is to titrate to a heart rate of below 65, because that appears to be where the benefit of the beta blockers actually exists. So most of the time, we would certainly not start a beta blocker, and we would not delay the patient's surgical procedure to do that. The other things I think that are important, if the patient does not go directly to the OR, is that there is, again, very good evidence that preoperative traction does not demonstrate any benefit, and that pressure sore prevention is important, and that the incidence of pressure sores is reduced if you use pressure-reducing mattresses. And once we've done all that, we take the patient to the OR. And so I'll ask Dr. Tatesman to come up and tell us about that aspect of it.
Thanks. So moving forward, we're going to discuss some of the surgical considerations related to geriatric hip fractures. The most common fractures in this patient population are femoral neck fractures and intertrochanteric hip fractures. We're going to talk for the next few minutes about fixation options and strategies, discussing advantages and disadvantages of both, and hopefully keep this really focused on literature-based evidence. But before we can talk about surgical strategies, I think it's really important to review our indications once again. The goals of operative management in hip fractures for the elderly patients are really for pain relief, for early mobilization, and to improve early and long-term function for these patients. I think given this, most of the non-operative management is really reserved for non-ambulatory patients, for patients too medically unstable to undergo surgical treatment, or patients really at the end of life. So let's first start with femoral neck fractures. As every resident in this room knows, there are many classification systems which we can use to discuss femoral neck fractures. Most of us have pretty much simplified this to two, displaced and non-displaced fractures related to the fracture pattern, with valgus-impacted fractures being grouped with the non-displaced fractures due to the fact that they're more stable fracture patterns and their treatment and their outcomes are more related or more similar to the non-displaced fracture group. So what are the treatment strategies? I'd say most of us would agree for the non-displaced fracture, some form of internal fixation is usually selected. Most commonly, this would be a combination of multiple screws or a dynamic hip screw, a sliding hip screw construct. Occasionally, angled blade plates or proximal femoral locking plates have been used, but definitely not as common as the other two. For displaced fractures in elder patients, arthroplasty is the treatment of choice, with hemiarthroplasty or total hip arthroplasty as the operation selected. While that seems all nice and clear and simple, there are some areas of debate and question related to this. I think we'd all agree that for displaced femoral neck fractures in young patients, some form of a reduction technique with internal fixation is the treatment of choice. However, for elder patients, arthroplasty would be what I think everyone here would choose. It's interesting, in the past, I would say about 5 years, there's been a lot of literature, particularly out of Europe, looking at this. And it's interesting because a lot of these folks, maybe 10, 15 years ago, were more advocating for internal fixation, pushing the age older. But the more recent studies really do reveal that arthroplasty is probably the treatment of choice for older folks, stating improved functional outcomes, fewer complications, and less revision surgeries. The real question is who's old and who's young, and I think that is really part of the area for debate in terms of both physiologic and chronologic issues. We often look to the Cochrane Review for some review and summary article, and this is one such hot topic which has been looked at in 2006. They considered 17 studies comparing internal fixation and arthroplasty for displaced femoral neck fractures in elder patients. In short, the summary is that there was less initial operative trauma when internal fixation is chosen. However, there's an increased risk of reoperation compared to arthroplasty procedures. Unfortunately, they were unable to make real strong definitive conclusions regarding pain, residual disability, mortality, hospital stay, and the usual statement followed of future studies are needed. So what are people doing? What are the trends? Dr. Bandari looked at this with an international survey, and it became fairly clear. Patients under 60 treated with internal fixation. Over 80 arthroplasty. And again, this group in question remains ballpark of 60 to 80 with mixed opinions there. We could spend the rest of the day talking about the option of hemiarthroplasty versus total hip arthroplasty for displaced femoral neck fractures when arthroplasty procedures are to be chosen. The pendulum keeps swinging one way and then the other way about which is preferred and which has more or less complications. This was a nice review that just came out in 2010 in the British Medical Journal, looking at 14 studies, of which 4 were randomized trials. The conclusions here were fairly straightforward. Total hip arthroplasty had lower reoperation rates and better functional hip scores, whereas hemiarthroplasty procedures demonstrated lower dislocation rates and fewer general complications overall. Again, these were interesting studies to review, and that many of these were trends rather than even truly statistically significant factors in very mixed patient populations. So what are we doing here in the U.S.? It's interesting, this paper looked at trends in the 1990s and how we're actually shifting our behaviors a bit, and really divided the 1990s into 3, the beginning of the 90s, the middle of the 90s, and the end of the 90s. And in the U.S., we've seen more hemiarthroplasties than internal fixation as a trend, more hemiarthroplasties than total hip arthroplasties, and more hip fractures being referred to the hospitals, teaching institutions. So in short, there clearly remains controversy over femoral neck fractures. I know of ongoing biomechanical studies looking at optimal constructs if internal fixation is chosen. It's clearly a national priority, and that NIH funding is going to several multi-center trials looking at different aspects of this, including the internal fixation, considering independent screws versus sliding hip screw, or DHS, and hemiarthroplasty versus total hip arthroplasty in controlled trials. So moving along, we'll talk about intertrochanteric fractures. Again, multiple fracture classification schemes exist. This is the AO-OTA fracture classification. And as you see, as we go from the top left to the bottom right, the fracture patterns become more unstable. The more pieces and the more distal the fracture goes, the more of a, quote, less routine intertrochanteric fracture I think we're looking at. Here again, there are multiple surgical options for fixation. I think there really are 2 implants that most of us turn to when we look to fix these types of fractures. Those are the DHS, the dynamic hip screw, or the sliding hip screw, and the medullary hip screw, the nail devices. Again, angled blade plates, proximal femoral locking plates, and arthroplasty can be selected, but probably are not the routine for the average fracture in the average patient. This topic even seems to be a little more exciting, with the Cochrane Review having multiple articles in the last decade, even several in a given year. In the last review in 2008, there were several conclusions. One, it became clear looking at this that orthopedic literature is all over the place, with 36 studies, all with multiple implants, multiple fracture patterns. It was hard to make any real definitive conclusions. Their net statement was this: sliding hip screws, or DHS, have lower complication rates compared to IM nails. Sliding hip screws appear to be superior for the trochanteric fractures. However, the conclusions did definitively note that many different nail designs and nail types are used in these studies, and many of the nails have even been changed since these studies were performed to address specific complications with specific implants. Also, when you read more carefully, some of the studies demonstrate a trend for superior outcomes with the nail fixation for select fracture types when the fracture patterns are more unstable, or you have a reverse obliquity or a subtrochanteric type of fracture. So given all that, what are we doing here in the U.S.? This is another project. Dr. Englund looked at the Boards 2, Part 2 collection data where surgeons come and present their cases, and in 1999, 3% of intertrochanteric fractures were being fixed with nails by young new practitioners, while in just 7 years later, with this scarce amount of data suggesting any improvement, 67% of patients were being treated with the nails in this group. So aside from implant selection, what are the other things that we can do to influence outcome in taking care of patients with intertrochanteric fractures or any sort of hip fracture? Well, I think technique is very important. And this is twofold. This is surgical technique in terms of your reduction, as well as your implant selection and application. This is an example of an intertrochanteric fracture that was fixed with a dynamic hip screw. While on the AP, you can tell, well, maybe something's not quite right. If you look at the lateral, which is the x-ray on the right, you can see that there's really about 100% displacement posteriorly of the femoral shaft related to the proximal segment. And this can be a challenging, if not predictably, a way to fail healing of this type of fracture. It's also important to understand the fracture pattern. If it's hard for you to understand it based on the views that you have, a traction x-ray can be very helpful in better understanding proximal femur fractures. Once you understand the fracture, it's important to select the appropriate implant. As you can see, this is another fracture fixed with a DHS, and even though it's already fixed, you can tell that the fracture is a little bit more distal than the usual routine intertrochanteric fracture. So while everything maybe looks okay here, predictably, this goes on to fail, needing revision to a blade plate. And interesting, we see several patients every year at Harborview where this is done and a DHS is used in a fracture pattern that may be more amenable to another type of treatment. So in short, what can we say about the surgical management of hip fractures? Hip fractures are routine, yet their surgical management actually is more complicated than we like to think. It is very important to understand the fracture pattern. Controversy does still exist regarding the optimal implants to be used, and there is still a role for further study. While good surgical technique and good surgery is important for patient outcomes, as we're hearing today, it's very important that we do this with a team approach to optimize surgical outcome and the best functional outcome for our patients.
Well, good job, Lisa. I'm going to talk a little bit about peri and postoperative management this morning, and I'll cover these 6 areas. Discharge planning, which actually starts at the time the patient enters the hospital through the ED, if not even before. Some thoughts about pain management and early mobilization, a little bit about delirium prevention, a problem which bedevils all of us in caring for older debilitated people in the hospital. Osteoporosis evaluation and treatment, what we'll often do with you after the patient's had their surgery, and a little bit about the long-term care service and our falls clinic, which many of you may not have been exposed to. We're envisioning between the geriatric service and the orthopedics team more and more close collaboration through geriatric fracture centers, which Grant's going to talk a little bit more about in a minute. But our vision of that is that discharge planning starts earlier and earlier in the process when an older person has a fracture, and it actually begins in the emergency department with the ED social workers who can help the patient and family start thinking about transitions after the fracture is repaired in keeping with the patient and family wishes for a rehab setting. A lot of older people don't mind going to a rehab facility for a week or two after a hip fracture, in contradistinction to what you might think. So if referrals are made even from the ED, or at least on day 1, there'll be less of a delay after surgery. And that might include the patient going home with ramped up care and with visiting nurses and physical and occupational therapy. I did want to mention the UW Medicine Long-Term Care Service, which I had, which many of you are very familiar with and use with great fluidity. It's possible, the more you become familiar with the long-term care service, to do some innovative things. For instance, a few years ago, Brad Henley and I had a case together where a patient came in the ED very early in the morning, was able to go straight to the OR, and actually went back to the nursing home and wasn't directly admitted to the hospital over a 24-hour period. We can also do virtual clinic visits. So for some people who are very debilitated, even post-operatively, and it's very difficult for them to come into clinic, it's possible for us to get x-rays in the long-term care facility, to send them to you digitally, to have you talk to the patient or family member over the phone. So some of you have used that over the years as well. So for the right patient, the right setting, that's great. We don't want to not have patients come back to see you in clinic if they want to, but if it's very difficult for them to do so, we want to facilitate your follow-up. Pain management is very important. I think over the past decade, we've become, as a team, more and more expert in doing this well. We do patient-controlled analgesia with fairly rapid move to oral meds as soon as possible. This is a team effort, and in geriatric fracture center thinking, there's no ownership of pain management. We're all competent physicians who know a lot about pain management, and we shouldn't necessarily only have the orthopedic service or only the geriatrics team working on that. As long as we work together with good communication, we can do a good job managing people's peri and post-operative pain. We will use scheduled long-acting medicines when necessary and breakthrough medicines and before physical therapy. It's often necessary for people to get a bump in pain medication. And we've become very aggressive about using different types of pressure-relieving mattresses to prevent pressure sores and to protect the wound area. Early mobilization is key. Dr. Abrass mentioned this. The quicker we can get people up and about, the better it is. And I've noticed over time liberalization among you all, among orthopedists, in becoming very aggressive in mobilizing people early. It does decrease the complications we all worry about, DVT and delirium, which I'll allude to a little more later, reduces deconditioning, obviously. And in DVT prevention, to the extent we mobilize, that's the key. That's better than anything. But compression and anticoagulation are obviously going to be important as well. Delirium is easy to prevent. Once it occurs, you buy into all the negative consequences of having delirium. And actually, delirium doesn't have a whole lot to do with physician work. It has to do with an interdisciplinary team, primarily with nursing and even involving family. It's much easier to prevent than treat once it's occurred. The tweaking with medications that we all often debate about actually is a minor factor in managing people with delirium. These patients we're talking about this morning are in pain. We don't want them in pain. We want to use pain medicine, even though those might increase the propensity of delirium. The actual way to prevent delirium is actually environmental and primarily a nursing function. It's routine, frequent orientation. You all see, even in the rooms, great big clocks so people can see what time it is, even if their vision isn't so good. Then every time the nurses walk into the room, asking them, do they know what day it is, do they know where they are, identifying them by name, their cells by name, using non-pharmacologic methods of sleep, getting people up and about during the day, involving them in activities and interaction, but at night, making it very quiet and very calm so people can get high quality sleep. Another way to get people tired so they sleep well at night is, again, aggressive mobilization and providing sensory aids. When people become sensory impaired, if they don't have their hearing aids, don't have their glasses, then they're going to sleep more and will run into problems with delirium. And actually, volume repletion turns out to be very important in delirium prevention, so making sure people are well hydrated. So it has very little to do with medicines and a lot to do with these kind of non-MD type of interventions. And by doing this kind of protocol, you can reduce delirium incidence by about 1/3. Osteoporosis management does start when people are admitted. We'll usually check a vitamin D level and we'll replete vitamin D and calcium because that's very important in people's overall health and particularly their bone health. Often we'll use bisphosphonates and check for the degree of osteoporosis later. That's not an urgency or an emergency. Sometimes bisphosphonates are helpful in pain management, but usually that can be a subacute consideration. We don't have to address that right away in the normal case. Other things to think about are urinary retention, particularly when using narcotics. Their bladders will not work very well, nor will their colons, so we have to work very hard on urinary function and anti-constipation measures. I&O catheter is much better than an indwelling Foley, so we try to get the Foleys out as soon as possible. And a good nutritional assessment is handy to do if there's time for it. We have a falls clinic at Harborview. It's an interdisciplinary clinic run by a geriatrician, but with therapists and others involved. Often, if people have had a fall and need further evaluation, and if it's okay with the patient and family, we'll actually refer them to the falls clinic. It's nearly a half-day evaluation, which reduces falls, and particularly injurious falls, by quite a bit. Dr. Phelan, our partner, runs that clinic. So do feel free to refer people to falls clinic if you think it's warranted. So I've talked a little bit about post-operative considerations. We've gone over the discharge planning, which we're moving earlier and earlier in the process. a bit about pain management and mobilization. I hope I've told you a little bit about delirium prevention so that we don't feel so guilty about it. It's more an environmental issue. The osteoporosis evaluation, which usually isn't an emergency, it's something we can do later, and I put in a word for the Falls Clinic. So at this point, I'll turn it back to Grant.
Thank you, Dr. McCormick. So Dr. Abrass, Tatesman, and McCormick have shared with us some of the ways in which care for these patients can be optimized. But I'd like to revisit briefly this slide and contest that there's probably still some progress that can be made. So what are some of the potential future gains? As orthopedic surgeons, we hope that we can impact the patient care through perhaps advancement in implants and refinement in surgical technique. But perhaps the greatest improvement can be realized through the implementation of some system-based changes, such as care pathways and multidisciplinary team approaches. This is a model that's been used and studied overseas for quite some time, but only recently has come to the United States. So I'd like to highlight one study recently published about 8 months ago, really the best study looking at this model in the United States. So there were two cohorts of patients. The first cohort was treated at a university hospital, and they received what's been called the usual care. And the usual care is fairly similar to a model that we use here, in that typically the patient is admitted to the orthopedic service with geriatricians or internists consulting on an as-needed basis. The other cohort was treated at a community teaching hospital where there was a dedicated geriatric fracture center. This center used care pathways and a true multidisciplinary co-management approach to treat their patients. Now, these two hospitals shared the same catchment area based in the same city. They also shared house staff and even some faculty. The baseline patient characteristics between these two centers were actually different. The patients treated at the Geriatric Fracture Center on average were older with more comorbidities and more likely to be living in a skilled nursing facility premorbidly. Despite these patients in the Geriatric Fracture Center generally being overall slightly worse off, they tended to fare better, at least in short-term outcomes. Those treated in the Fracture Center tended to have lower overall complication rates, shorter lengths of stay, and there was even a trend towards impact on in-hospital mortality. So while this is by no means the definitive or exhaustive study on this subject matter, it should give us pause for thought that perhaps some of these system-based changes can make a significant impact in the quality of care that these patients receive. So with that, I'd like to invite the panel back up to revisit some of our cases. By way of review, our first patient is a generally healthy woman who broke her hip playing tennis. And by reminder, this is her x-ray, an intertrochanteric femur fracture. And I'd like to pose the first question to Dr. Abrass and say that this patient seems like a good candidate for somebody who could benefit from an early surgical intervention, and what steps are important to take, or maybe more importantly not take, in order to ensure a safe and expeditious trip to the operating room.
So this is a good example of someone who we would see and discuss with the orthopedic surgeons to go to the operating room as quickly as possible. There's really no reason for delay. You saw the history. She had osteoporosis and hypertension that was well managed, and there's really no reason to delay surgery. So one of the benefits that we've shown you, and the evidence is really very good, that the earlier she goes to the operating room, the better we would manage. So, Dr. Chapman.
I have a question. So I spent some time in England, and they were very keen on not putting these patients to sleep, claiming much lower complication rates by putting these patients under a spinal anesthesia or something like that. Yeah. And I guess some of the local hospitals pursue a similar strategy. Are you aware of any comparative data in that regard?
So, again, there's not really good evidence that's better. Certainly the whole issue of the recovery phase for those patients is significantly shorter. We've seen that, but there isn't other outcomes that have been looked at from the way that's done compared to doing general anesthesia, which is the procedure I think you all do most of the time with our patient population. But I think those are things that, again, probably need to be carefully assessed to see whether you can reduce complications, and certainly in the sense of getting people mobilized and active immediately after the procedure. I think anybody who's had general anesthesia knows that they just don't feel well for a while. That takes recovery. I don't know if any of you have ever had general anesthesia, but if you have, I've seen patients, I personally haven't, but if you've seen patients, that they really, their recovery phase is not just from the surgery, but actually from the anesthesia. They don't, their level of fatigue, their thought processes, their ability to manage complex issues are really quite different. So I think if we can reduce that by not giving them a general anesthetic, that needs to be looked at. But that's not what's been looked at, actually. But I think that's the long-term benefit. Again, in this person, the sooner she goes to the OR, the better off she would be. And then with what Dr. McCormick told you, she probably wants to play tennis again. She's competing at her club's 70s, over 70s tournament, and so she's going to want to be as active as possible. So again, I think for her, post-op day one means sitting up at the bedside certainly by the middle of that post-op day, and probably up with PT by the end of the first post-op day. And having her leave the institutional setting as fast as possible, probably by post-op day 3, she should be out of the hospital and active, and whether that's at home or in a skilled nursing facility where she's going to receive her rehabilitation, probably doesn't matter. It depends on the resources that are available. But that's what I would recommend in getting her back home and active, and potentially as active as possible. And she might be one of those people that's in that 20% who actually return to their usual level of activity.
I'd like to make one other comment, which Dr. Chapman has really started to touch on with the question, is just to further discuss the impact of these multidisciplinary care teams. And I think that while we're standing here from orthopedics and geriatrics, all the projects we're talking about, the papers and the studies, these multidisciplinary teams include anesthesiologists and the physical therapist and the discharge planner and the emergency department. And all these folks are on board to then be able to better address in the specific patient population groups what forms of treatment are best and really work on these pathways to improve care. So I want to make sure we didn't leave those people out in terms of discussion of these groups.
Absolutely. So Dr. Tatesman, how would you fix this fracture?
So I think what we see here is a seemingly routine intertrochanteric hip fracture. I think based on what I know and what I've read, I think that there are several options. I personally would pick a DHS, a sliding hip screw for this. But I think the literature is mixed, and one couldn't be truly faulted for using a medullary device.
Maybe something like that.
Something like that. So I think a reduction is important. I think obtaining a reduction in a closed or an open manner is important. I think bone stability and enhancing your construct with a good reduction is important, and not just to poo-poo this as an old person who it just doesn't matter. That's the wrong answer in my mind. And then placing your implants appropriately. So I think this is a reasonably placed implant in a reduced fracture.
I don't want to monopolize questions, but is this a patient who can then weight bear right away? Dr. McCormick was talking about the difficulties in trying to establish protected weight bearing, and this is one of those orthopedic instincts that I think has been passed on from generation to generation to institute protected weight bearing. I don't know, how realistic is it actually to protect weight bearing in the patients that you see?
Well, this is an interesting nether region between what we would think and what you all think. If we're reluctant and hesitant about weight bearing, I fear that makes you reluctant and hesitant. If you're reluctant and hesitant, It makes us reluctant and hesitant. So the more we can be open about that and maybe get a little more risky about it. If there's one thing I've noticed in the past decade is that your group has gotten more and more aggressive and courageous about mobilizing people earlier and not doing the weight bear as tolerated, partial weight bearing stuff. Just go for it. You know, to your pain level, start mobilizing, which I'd appreciate hearing from other members of the group about the wisdom of that and if that's a trend in orthopedics generally.
I think there is some data to support that patients can be weight-bearing as tolerated. I think that is being done with the caveat, though, that they are at a falls risk because they failed to get there. And I think with anesthesia and pain and a fracture, they may be at an increased falls risk. So I always like to see them with something in their hand to help stabilize and improve and prevent falls. But I think the trend, based on some literature evidence, is to proceed with more aggressive weight-bearing rather than protected.
Yeah, I think even if they are weight bearing, again, because of the pain, they're not going to be fully weight bearing. I mean, it's tolerated. So they're going to need an assistive device, and we definitely want them to reduce their risk of falls. So that doesn't mean they shouldn't use a walker. But again, this woman might have enough upper body strength to actually be able to toe touch or not bear weight. But our second case, that woman is not very likely to have upper body strength to truly be able to do it. So they end up bearing weight anyway, and it's just as good to see if they can do that while you're supervising them and seeing if they can tolerate it as opposed to having them do it and for you to have instructed them to do differently. I don't think many of them can do it. Yes.
Yeah, hi, Bob Dunbar, Harborview. I was just going to comment on this as well, and I think there is some evidence that's been shown from the group in New York that patients do tend to auto-regulate. But I would also say that among ourselves, just as you noted, that there is a growing appreciation that if you're doing an operation that you're not prepared to have this patient weight bears tolerated immediately post-operatively, perhaps you're doing the wrong operation.
You know, there's one other point that I think you all might be interested in hearing, and that is you've actually handled the patient's bone. You've screwed things into the bone, and you have a feel for the bone substance, and we value that information. So that might be the kind of thing that goes into your consideration about being careful about weight bearing. And we would love to hear about that, you know, your impression of actually having handled the bone and screwed instruments into it.
Dr. Kringle?
Two questions. One's kind of a silly question, which is there a good reason to leave the middle screw out? I keep seeing this, and the 37 seconds it takes to put in the screw, it just doesn't seem to make sense to me to leave it out all the time. Second is, this type of patient frequently presents with a remote history of atrial fibrillation on Coumadin, and even more frequently now on Plavix for not severe heart disease. And I'm interested in the medical team's recommendation on managing the timing and so forth on the patient on Plavix and the patient on Coumadin with non-symptomatic atrial fibrillation.
So Dr. Tatesman, do you want to field the first question?
Sure. I think that in terms of implants and number of screws, I think a 2-hole side plate is perfectly adequate for this fixation. I think we actually, I don't recall the specifics and why it wasn't used, but occasionally we just can't find that plate, or we're out of plates because we fixed too many maybe. And I think that the plate length, if you're in general fracture fixation, plate length is probably more important when there's adequate number of screws. And just as it may take a couple more seconds, well, it takes a couple more seconds, and there's an additional cost, maybe not a fortune for a screw or two, and if 2 screws is all you need, why put more? So.
Well, I actually should turn it around to all of you from a blood loss perspective. Most of the procedures we see, and your notes from the OR, is that at least during the procedure there's relatively little blood loss. But what we see in these hip fracture patients is they come in with a hematocrit of 40, And by the time we see them the next day, their hematocrit's 24. So I think the whole issue is that they probably bleed into their hip some before you all do the procedure, and then they probably leak after. As you all know, there's plenty of room and not really that much tissue turgor in that area, and I think they do bleed. So I think at the moment, you'd sort of have to, we'd need to work this out together really to think about whether you really want to reverse these people. Certainly we would hold their Coumadin before the surgery. You need to tell us whether you think it should be an INR of 1.7 or less. Certainly the risk of bleeding at that level goes way down, so we would do that. We can certainly reverse that fairly quickly to get them to 1.7 fairly quickly, not to normal. So if that's what you want. And then usually we wouldn't do platelet transfusions for the Plavix, but if somebody really had a major risk for more bleeding because you think it's going to be a complicated or prolonged procedure, we could reverse it. But typically we wouldn't recommend platelet transfusions.
We have just enough time for our second case. By way of reminder, this is an older gentleman who is more frail and in declining health with a significant number of comorbidities. He already is living with his son for some extra help. And so actually I'll pose the first question to Dr. Tatesman and ask her whose responsibility she thinks it is to discuss with the patient and the patient's son really the gravity of this situation with regard to the mortality and morbidity associated with this type of fracture in an older individual.
I think it's everybody's responsibility. I think from the surgical side, as the group of people who are going to be fixing these injuries and discussing this with the patients and their families pre-operatively and post-operatively, I think it is our obligation to discuss the mortality issues and some of the long-term function issues. The timing of that discussion or those ongoing discussions is a bit variable. I think sometimes you don't have to hit everybody with this whole hour-long thing right up front, but I think it's important to open those conversations and impart the fact that this is a severe problem and some patients will die in the near future or in the semi-near future given this.
Dr. Abrass, this clearly is a more frail patient. He does not recall the circumstances surrounding his fall. If you were evaluating this patient in the emergency department, how would you approach this compared to our first case?
So this is not somebody I would take to the OR right out of the emergency department, although again our goal would be to get the patient to the OR within 24 to 48 hours despite the frailty issues. So the real question here is somebody who has coronary artery disease, is this active coronary artery disease? And certainly we would want to rule out an acute myocardial infarction, which we easily can do within 24 hours between our EKG monitoring, and we would probably put this person on a telemetry floor where we could monitor them for 24 hours for an arrhythmia, since the loss of consciousness, if it had occurred before the fall, would be more likely due to an arrhythmia than it would be to anything else, and so we would do that. Probably in the ED, they would get a trauma series, so we would probably have a head CT to make sure there was no intracranial lesion, either as a cause of the fall or as a consequence of the fall. But I think assuming this patient really does not have an acute coronary event or an arrhythmia that explains this episode, we would recommend that the patient have a procedure done within 24 to 48 hours. Remember, what we're doing is trying to reduce the risk. There's no question that this patient is at risk when they go to the OR. That's really not something we can truly change in this person. What we can do is reduce that risk by assessing the things that we might do to delay the surgery. But after that, his risk waiting any longer would make no difference. So as long as the discussion with him and the family was assuming he actually can make that decision himself, certainly he himself would make that decision, or the family, And if that's what they'd like to do, because he was ambulating, he was active, he was having probably what he would say was a satisfactory quality of life, and he probably wants to ambulate again, and we certainly want to do that as quickly as possible. We would monitor him post-op, so he again would go to a tele floor post-operatively, and then we, in the future, could evaluate his risk for falls and trying to prevent the falls from happening again. I think preventing falls and another fracture will reduce his morbidity and mortality.
Dr. McCormick, perhaps this patient's greatest challenge as far as what stage of care will come in the post-operative period, and Dr. Abrass has already alluded to some of the challenges, but where do you see the greatest problems coming, and how would you address those?
Well, Dr. Abrass mentioned the perioperative risk. The risk of this patient for delirium is extremely high. We should assume this patient will have delirium post-operatively. Less than half of people with Alzheimer's disease in the community carry that diagnosis. Most dementing illness is brought up this way, early memory loss, when the patient actually has fairly advanced Alzheimer's disease. They've moved in with the son. That's a hint that this patient is dependent. This particular episode of fracture may be a precipitant of the patient going to a long-term care facility, if not temporarily, permanently. We can help smooth that transition. The fact that the patient will be complicated, likely will have delirium, doesn't necessarily mean their length of stay is going to be enormous. The delirium piece actually isn't that much of a barrier to placement in a long-term care facility, especially if I'm on the receiving end. If our team are both seeing the patient in the hospital and helping move them and transition them to a rehab setting, we can help with that transition. So even though the patient's length of stay is likely to be somewhat longer than our first patient, I think if we work together as a team, we can minimize the morbidity of the dementia and delirium, minimize the perioperative problems that may occur, and move the patient to a calmer rehab setting earlier than you might think.
Okay, and with that, I think we're out of time. I'd like to thank our panel again.